Hello everyone. So today we are going to discuss a very important disease called COPD, chronic obstructive pulmonary disease. And many of us know what is COPD, but when you have to write in the exam, then it's going to be a different format. Right? So we'll go in that format today. So COPD, first we'll write about definitions of how you define COPD. It is a chronic obstructive pulmonary disease and it has an airflow limitation, which is irreversible, or you can say it's not reversible. So when there is an airflow obstruction or limitation and which is not fully reversible, then we call it the COPD, and we define it into three types. Remember, one is chronic bronchitis, okay, second is emphysema, and third is small airway disease. So these are the three different branches of COPD. Okay, bronchitis, that is chronic bronchitis. If there is a bronchitis without any airflow obstruction, then we don't include it in COPD. Okay, so chronic bronchitis, that means with airflow obstruction. Second is there is emphysema, and third is small airway disease. And when you write in the exam, you write in this way. You write the causes. You write the definition, types, then causes. Then you have to explain it in three different varieties. You have to explain three different. That you write about pathogenesis, then pathology, pathophysiology, before writing the clinical features and treatment. So these are the three things that you need to know, and they are separate. Remember, they are separate. And if you write like this in the exam, definitely you can score a very good marks. Okay, so we'll go with a little bit now the types, and we'll explain everything in detail. Right. So, what are the causes for COPD? You know, most important cause is smoking. So most important cause for COPD is smoking, and apart from smoking, there are some environmental factors like occupational hazards, like people working in coal industry or textiles, minings, all those dust particles, they can cause COPD. Along with that, there is also a genetic factor, that is people who are genetically deficient in alpha-1 antitrypsin, which we'll discuss it in later. But remember one thing, that only 1 to 5% people are having COPD due to genetic causes. Okay, so alpha-1 antitrypsin is less common than the cause of smoking or environmental pollution or some occupational exposures. So before going to pathogenesis, pathology, pathophysiology, let's little bit understand what is bronchitis, what is emphysema. Now, let's say this is the trachea dividing into bronchi, which is subdividing. And here is the alveoli in the terminal duct. So I'm just making sure. So emphysema is here. This is the place where the emphysema takes place, in the terminal duct and in the alveoli. And bronchitis is here in the airways. So bronchitis takes place in the large airways, and emphysema takes place in the terminal end, the terminal duct in the alveoli. Okay, so here is the bronchitis, and this part is the emphysema. All right. So what happens in bronchitis? Basically, there is two things occurs in bronchitis here. There is goblet cells and submucous gland. So these goblet cells and submucous glands, what they happen? It happens that they are in hyperplasia. They becomes hyperplastic. Hyperplasia. So let's say this is the large airway, and here there are some glands which are submucous glands. So these are submucous glands which secretes mucus. So they secrete mucus. And there are some goblet cells. So these goblet cells also secretes mucus. So what happens in chronic bronchitis, due to whatever be the cause, though smoking is the most commonest cause, there will be hyperplasia. So they will increase in number. So these goblet cells will increase in number. And as a result, there is lots and lots of mucus found in the airways. Plenty of mucus. So this mucus is causing what? They are causing airflow obstruction. So because of the presence of mucus here, there is airflow obstruction. Right? So there is airflow obstruction here. And remember, in COPD is an obstructive pulmonary disease. So airflow obstruction is more pronounced when we try to expire. So expiration is more difficult. So expiration is more pronounced than inspiration. Now why is that? Because normally in inspiration, these airways, they are normally dilated. Physiologically they are dilated. When we inspire and take a long breath, these are dilated. And in expiration, everything is recoiling. When we are exhaling air, these airways are recoiling. They are recoiling back. So they are physiologically, they become smaller in diameter. So because of that smaller in diameter physiologically, plus there is abundance mucus, so obstruction is more difficult, means during expiration. That's why in COPD cases, we will find that patient is finding difficulty in producing expiration, in expiration of air, that is forced expiratory volume in 1 second is significantly reduced. That explains why FEV1, FBC ratios decrease in obstructive pulmonary disease or COPD. So because of obstruction. So what happens in bronchitis? There is narrowing of the airways, okay, and because of mucus, there is hypermucus secretions, and plus what? And there is also, along with that, we know these cells here, we have a cilia here. These are hair-like cells, cilia. There is ciliary destruction also. So now the cilia is being destroyed and abundance of mucus. So what is happening here? That the whole mucociliary escalator function, that is one of the important functions of our respiratory system. The mucociliary escalator function is not working. Okay. So as a result, the mucociliary escalator function is not working. As a result, this mucus is now stagnant here, because the cilia has a beating, it has a movement, that is, this cilia beat towards upwards, and so that it can clear the mucus. So the cilia is beating continuously. It's like an escalator action. So it is continuously beating the mucus upwards. So now when this function is lost, this mucus has become stagnant, and as a result, it is obstructing the airway. So you can imagine this is an airway, and then it has lots of mucus. It has lots of mucus inside. So as a result, the lumen of the airway becoming quite narrowed. So again, remember, expiration is more difficult here in COPD than inspiration. That's why we know that when there is expiration is difficult, it produces sound. So that's why when the sound comes out of this narrow airway, it will produce a sound, but it's called wheeze. Okay, remember, wheeze is an expiratory sound, wheeze. Okay, and stridor is an inspiratory sound. Okay, so that's why wheeze, when we hear a wheeze, you have to know that this is going to be COPD. And when we examine in the lab, we know FEV1 is quite reduced because person is facing difficulty in expiration. So in the very first second, the whole expiratory volume is decreased. So that's why the FEV1 LBC ratio, which is normally 80%, it goes down below 80%. okay, which signifies again in a that it is the case of COPD. Okay. Now what happens in emphysema here? So this is the case of bronchitis. That's why in bronchitis there is chronic persistent cough with sputum. Remember that. If a person has a cough with sputum, we will not say COPD. Remember, there should be airflow obstruction. That is only that defines the criteria for COPD. So in COPD there is chronic persistent cough with sputum or phlegm. Chronic persistent cough with sputum for more than, you can say, 3 months or consecutive 2 years. Then we term into the COPD. So what happens in chronic bronchitis? There is goblet cells, submucous glands which are become hyperplastic, mucus is being produced and it is not being cleared because of the deficient or the defective mucociliary clearance function or escalator function. So as a result, it is obstructing the airways. So that's why there is a obstruction of the airways and air has to pass through a very narrowed lumen and producing a wheeze sound. Okay, that's why there is wheezing. So that is explaining the bronchitis. Now what happens in emphysema? So emphysema is a disease of the terminal ducts, okay, where there is the alveoli are there. So what happens in emphysema? Okay, we'll go to the details in pathogenesis. So this alveolar septa you see here, alright. So these are alveoli and these are alveolar septa. So these are alveolar septa. These are the walls. So what happens in emphysema? These alveolar septums are perforated. So they are damaged. So as a result, now whole this thing will become a abnormal big alveoli or big air sac. Okay. So let's imagine there is 3 alveoli here. Now because of the destruction, they will be communicating. Each of this cavity, each of this alveoli is communicating with each other, and it will become an abnormally permanent large air sac. Plus there will be what happens in emphysema. Plus there will be airways. Plus there will be also obstruction. So first thing, what happens here, these alveoli, they have become permanently bigger and there is obstruction. So what's happening in emphysema here is air trapping. There will be air is trapped. Okay. So in emphysema, there is air is trapped because of the destruction of the air sacs. This is destruction of the walls, this is partitioning the alveoli, and they are all becoming a one big alveoli, resulting in air trapping or hyperinflation. Alright, so that happens in emphysema. Now we'll go in details what is the pathogenesis, why it happens. Okay, so in the exam you have to write in 3 different steps. You write pathogenesis, you write pathology, then you write pathophysiology. So now we will discuss what is pathogenesis. So when you write pathogenesis of COPD, remember first thing you will write about fibrosis. So fibrosis is the main contributor in resulting COPD. Now what is fibrosis? Now these are the airways, okay, which are dividing, and these are the alveolar sac. Now whenever there is any deposition of connective tissue in the extracellular matrix, so let's say there is deposition of the connective tissue in extracellular matrix. Okay, deposition of the connective tissues. It can be due to healing process or it can be due to pathological inflammation process. So whenever there is any deposition of connective tissue in the extracellular matrix, we call it fibrosis. In COPD, fibrosis is one of the very common factor because of there is tgf-beta, which is being released in a abnormal high manner. Okay, that is transformation growth factor beta. Okay, this is the thing which is responsible for the fibrosis all around. Another thing why fibrosis is caused by tgf-beta, another thing is that what happens here in COPD, there is, so what happens with that? Okay, we know that there will be, now what happens, there are locally here is the macrophage. Okay, the macrophages are normally patrolling the alveoli. Macrophages, they are normally patrolling the alveoli. Okay, they are our defense mechanism. Let's say now because of the smoking, so what the smoking is, so now the smoke particles, that is the oxidant stress, we say oxidant stress. So when the smoking is coming, when a person is smoking, then this smoking is activating the macrophages. The smokes that is inhaled, it activates these macrophages. Okay, so it activates the macrophages. So when these macrophages are activated, so they are releasing proteases. So these proteases are very important thing because they stimulate this tgf-beta in causing fibrosis. That's number one. Number two, in pathogenesis is there is inflammatory cell recruitment. Okay, that we call inflammatory cell recruitment, which is in continuation with this. Now look what happens here, because of smoking, macrophages are stimulated. So when macrophages are stimulated, so what will they do? They will release proteases and they will release cytokines. So lots of cytokines will be released here, lots of cytokines. So plenty of cytokines will be released. So these released cytokines, they will invite neutrophils. They will invite neutrophils. So neutrophils are now coming from the surrounding blood vessels. Neutrophils are joining here. So plenty neutrophils here in the scenario. So what is happening here? There are neutrophils also. These are neutrophils. So these neutrophils, they secrete a very important component called elastase, which is also a type of protease. So this elastase, what they do, they destroy the extracellular matrix. Okay, this elastase, what they do, they destroy the elastin part, elastin, and also they destroy the extracellular matrix. Now what is an elastin here? Remember, the elastin gives the lung parenchyma stability. Okay, so what these are alveoli. So what are present here? These are here. It is elastin. Elastin is present here. It is a part of a matrix that is providing stability to the parenchyma. Also, this elastin is present all over this alveoli. Okay, you can imagine here. This is an alveoli, and it has an elastic band called elastin. It is an elastic band. Now look, if we remove this elastic part from this alveoli, what will happen? They cannot recoil. Like for example, if you wear a pen that has got elastic band, or which has got an elastic in the band, then you can imagine if we remove the, so because of the elastic band, it's being tight, it holds your waist, right? So if you remove that elastic part from your waist, so you can imagine it will not hold your waist, and there will be you're losing your pant. The situation will be losing your pant, because that elastin, the elastic material in your pant, it grabbed, it makes a grip. Because of the recoil property, and it makes your pant holding your waist. So same way, if you remove this elastin from the alveoli, now this alveoli cannot recoil after inspiration. In the inspiration, it can expand. It's not a problem in inspiration, because air is coming and it is pushing the alveoli. So it can expand. But what's happening when we are pushing out, when we are trying to expire? When we're trying to expire, they need to recoil. So the recoiling capacity is given by the elastin fragment present in the alveoli and in the matrix. So this elastin, if it is damaged by the elastase and the protease enzyme, so what will happen? They cannot recoil. So as a result, air is being trapped, and the person has a difficulty in expiration. So that is why there is, because of the elastase secreted by the neutrophils and the other proteases secreted by the macrophages. So this protease, what they are doing, they are destroying the extracellular matrix. Plus this elastase is destroying the elastin. So as a result, because of this inflammatory cell recruitment, okay, this neutrophils, elastase, cytokines, what is happening here? There is air trapping here. So because of the inflammatory cell recruitment, there is air trapping, and it is resulting in COPD. So this is one condition that is you can write in pathogenesis. There is inflammatory cell recruitment, where you will mention about macrophage. You write about neutrophils, then cytokines, also interleukin 8, and tumor necrosis factor alpha. So all these are inflammatory cells, where they come in inflammation, because there is a process of inflammation that starts here when a smoke comes and activates the macrophage. So this is one, fibrosis occurs in pathogenesis. Number 2 is inflammatory cell recruitment. Then what is happening in number 3? There is direct cell damage. Okay. Number 3 is direct cell damage. So this oxidant stress released by the smokings, okay, they are directly destroying the pneumocytes. They are directly destroying the cells. So they are directly destroying the cells here. So cells, this is pneumocyte type 1 and type 2 both. Both the pneumocytes are being directly also damaged by this oxidant stress released by the smokings. Okay, and we know that there is surfactant is also released by this type 2 pneumocyte. So there is fibrosis, there is inflammatory cell recruitment, then there is loss of surfactant cells, okay, and there is direct cell damage. That is number 3 in pathogenesis. Okay, and what is number 4? Inability to repair. Our lungs has a limited ability to repair this elastin. Okay, so we know that there is a balance, because of there is a balance here of elastin and anti-elastin factor. So when there is lots of elastase here, we have a balance. It is being neutralized by anti-elastase factor, that is alpha 1 antitrypsin, which always inhibits. So there is a balance here. Now in a long time progression of the disease, what happens? This balance is lost when there is more production of elastase in relation to the production of alpha 1 antitrypsin. Then what will happen? Then it will go for the COPD. So whenever this balance is lost between alpha 1 antitrypsin and elastase, then our body cannot repair anymore. So we have a limited ability. That's what I am telling you. We have a limited ability to repair. So there is a proper balance, which is called elastase and anti-elastase theory. We have a limited amount of antitrypsin, which is alpha 1 antitrypsin, which is being produced to combat, to fight against the elastase. But if your production of elastase is more than it is produced, then it can result in COPD. Or if genetically some people are deficient of alpha-1 antitrypsin, okay, then also it can result in COPD. So this is the balance which is being lost, and that's why our body goes for inability to repair mode. And these are the 4 pathogenesis. When you write pathogenesis for COPD, you have to write fibrosis, then inflammatory cell recruitment, then direct cell damage, and number 4 is inability to repair because of the loss of balance of alpha-1 antitrypsin and elastase. Okay, so that comes in the pathogenesis. Now we'll go for pathology. So pathology, when you write pathology, you will divide the COPD into 3 types. Okay, you will divide the COPD into 3 types. That is, what happens pathology in large airways, what happens small airways, and lung parenchyma. So large airways, as you know, what happens in bronchitis. Okay, so when you write pathology, so question might come as a pathology or pathogenesis or pathophysiology. I am telling you because these 3 things are different. So large airways means we are talking about bronchitis now. So what happens? We know there is mucus glands and goblet cell hyperplasia. They become hyperplastic. And as a result, there is cough plus phlegm or mucus, which is called as chronic bronchitis. That happens in large airways. Now, small airways, we mean, what are the small airways? We mean those airways which are less than 2 millimeter of diameter. So these are small airways. So in the small airways also, there will be goblet cell hyperplasia, there will be mucous gland hyperplasia, plus there will be here loss of surfactant secreting cells. And what happens? There will be in the small airways, there will be lots of mononuclear infiltrates, plenty of macrophage, what you call mononuclear infiltrates. Plenty of macrophage will be there. Plus, there will be smooth muscle hypertrophy. So as a result, together they are causing what? They are causing luminal narrowing. So the airways are normally, this is airway, now it has got narrowed. There will be luminal narrowing because of so many combined factors. So loss of surfactant, mononuclear infiltrants, plus smooth muscle hypertrophy, plus edema. Along with mucous gland hyperplasia and goblet cell hyperplasia. So along with this, it is causing what? Overall, what is happening here? There is loss of so what is happening here? There is destruction of the extracellular matrix. Means these are the airways, we know, and these are the alveoli. So it's destruction of the extracellular matrix, the matrix that is surrounding this matrix, which is surrounding this alveoli. There is destruction of the extracellular matrix that takes place in small airways. So along with extracellular matrix destruction, which you have to mention in small airways, don't forget, extracellular matrix is destructed. Destruction of the extracellular matrix along with all these points that takes place in small airways. So they are, you can say this is bronchitis, and here bronchitis so in small airways also, and plus little bit, you can say this is a mixed kind of variety where both is happening in small airways. And what happens in lung parenchyma? We mean what happens in emphysema. So lung parenchyma, we know what happens, that the alveoli there is, as we discussed earlier, in the alveolar septum there is perforation. There is perforation. So what is happening here? The air is communicating here. So now they are not individual sacs. Air is moving from here and there. So it will become abnormally large one sac. Okay, that is called, we call that as the emphysema. So in emphysema there is this wall's alveolar septum is being destroyed. Why? This we already in pathogenesis we know there can be because of elastin damage which is being destroyed. Okay, and so because it cannot recoil, that is number one, elastin, and number two is that there is these alveolar septums are perforated. So as a result of because of this extra matrix thing, so as a result these alveoli are now becoming one sac. So air trapping. So what is happening here? Air trapping. So we call emphysema. Now when you say emphysema, it can be panacina or it can be centriacina. Okay, it can be, when you say emphysema, it can be panacina or centriacina. Now when you say centriacina, most of the time it asks in MCQ, centriacina and emphysema. When there is a, is most common in the upper lobe, and C for cigarette smoking. So, or it is upper portion of the lower lobe also. Okay, upper lobe and cigarette smoking, and there is a big one alveolar sac that is present and is causing, when we call centriacina. When in contrast to centriacina, what is panacina? When it is all over the lungs and it is more present in panacina is, okay, so panacina I am writing here. So panacina is more common, is present with alpha-1 antitrypsin deficiency, alpha-1 antitrypsin deficiency, and it is more prevalent in lower lobe. So panacina, as the name suggests, panacina, it is scattered and all over the lungs, and it is more present in the lower lobes. Okay, and it is mostly associated with alpha-1 antitrypsin deficiency, while centriacina is one of the it is most common pathological manifestation of cigarette smoking, and it is more prominent in upper lobe. So what happens in lung parenchyma? There is destruction of this alveolar septa with the destruction of the extracellular matrix, that is due to elastin. So the elastin fragment is destroyed and these alveolar septa are destroyed, so they lose the recoiling power, and it becomes a, instead of 3 or 4 alveoli, small alveoli, it has become now one permanent. It is irreversible, remember. It has become one permanent alveolar sac, okay, which is having a difficulty in forcing the air out because there is no recoil capacity here, no recoiling power. So there is permanent air trapping is present here. So this explains that when explains the barrel shape, why the chest becomes hyperinflated in emphysema. So because of air trapping, there is a, now the chest looks barrel shaped in emphysema. That is one clinical finding, and also one of imagine this situation. Okay, so okay, I'll remove this part. So what's happening here? Now we know this is a diaphragm. So diaphragm is dome shaped. Now this lung has hyperinflated because of multiple alveoli are affected. It has become hyperinflated. So now this is the normal lung. So what is happening here is, let's say this is the affected lung. So this is hyperinflated now. This is hyperinflated lung. Okay, though this part is affected because lots of air is inside, so hyperinflated lung. So this hyperinflated lung, what will happen here? It will make the diaphragm flat. So because of the pressure, there is a flattening of diaphragm here, which is an important radiological feature in COPD, flattening of diaphragm. Okay, so these are the 3 pathology findings. One is large airways, small airways, and in lung parenchyma there is perforated walls, then there is large abnormal air sac is produced, and there will be lots of macrophage also come into the scenario, and then it can become either centriacina or panacina. So this is the pathology. Now let's go for the last important point in today's class, that is the pathophysiology. What happens in pathophysiology? So next is pathophysiology. So when you write pathophysiology for COPD, you write in 3 headings. So this first thing it happens is airflow obstruction. Airflow obstruction. The next you write about hyperinflation or air trapping, and then next you write gas exchange. So when you write pathophysiology of COPD, you write in 3 headings. Okay. So the first thing is that airflow obstruction. Second is hyperinflation. Third is gas exchange. So as we already discussed in pathogenesis and pathology, so what happens there is airflow obstruction. In bronchitis there is lots of mucus. So there is defective mucociliary clearance, and there is this, as a result the lumen is being narrowed, airflow obstruction. What happens in emphysema? There is hyperinflation because there is one large sac. There is hyperinflation. Okay, so we discuss in pathology, this air alveolar septums are destroyed. So as a result, it becomes one large sac, which is not recoiling, which cannot recoil. The recoiling capacity is being lost because of loss of elastin and destroy or perforation of these alveolar septums, and they are becoming one alveoli which cannot recoil. So this recoiling capacity is lost. So as a result, there is hyperinflation, or we call barrel-shaped chest, which is an important thing in X-ray, and we noted that it can also cause flattening of diaphragm. So normally the diaphragm is a dome shaped. We know that diaphragm is dome shaped. Now what will happen if we flatten it? Okay. So what can be the consequence if the diaphragm is flattened? Okay. You have to imagine the situation here, that the diaphragm here, okay, it is also pushing the abdominal muscles. It is opposing the abdominal muscles. This diaphragm is opposing the abdominal muscles. So let's say this is abdominal muscles. This is the abdominal muscles. Okay. So this diaphragm is helping in inspiration by pushing the abdominal muscles downward. It is pushing the abdominal muscles downward. Now, if we make this diaphragm, which is dome shaped, flat, what will happen? Okay. Let's make the diaphragm flat. Okay. So this is the abdominal muscles. These are the abdominal muscles which goes down with the pressure of diaphragm. And now the diaphragm is flat. So instead of curve, now the diaphragm is flat. So you can see if there is flattened diaphragm, there is less apposition, less contact with the abdominal muscles. So because of less contact with abdominal muscles, this diaphragm cannot push the abdomen effectively in comparison to this picture. So this diaphragm cannot push these abdominal muscles effectively in inspiration. So inspiration will be, so normally what happens when you inspire, this diaphragm goes down, pushing all the abdominals and making way for the lungs to expand. So that's why there will be the tidal volume will be severely affected. Okay, the tidal volume will be severely affected. That's why people always have a shortness of breath or exertional dyspnea in COPD. This is the reason that they have shortness of breath. Okay, there is shortness of breath or exertional dyspnea because of the flattening of the diaphragm, which takes place because of hyperinflation of the lungs. Hyperinflation is because of the rupture of the septum of the alveoli, and alveoli fuse together and they cannot recoil. So plenty of air is still in the lungs. So when the lung is expanding, it is making the diaphragm, it is giving pressure, and diaphragm is flat. Okay, instead of dome shape. So this diaphragm is now not fully opposed to the abdominal muscles that can push it down during inspiration and making way for some free space for lungs to expand. That thing. Third is the gas exchange. So as we discussed in pathophysiology, you write three things. One is airflow obstruction. You write airflow obstruction. Number two, you write hyperinflation or air trapping. Number three, you write gas exchange. Now this is the alveoli, and this is the blood vessels. Now in COPD, we know it cannot in emphysema it cannot recoil. So there is air trapping. Or if this is bronchitis, we know there will be obstruction. So whatever be the cause here, what is happening here? Gas exchange is not taking place. It's going down. There is limited gas exchange in COPD. So gas exchange means oxygen has to go here and carbon dioxide has to move here. So this gas exchange is being effected. So now this blood is carrying, a lot of carbon dioxide, which needs to go out, and it has to take oxygen. So now here what happens? Ventilation is, perfusion is okay. The blood, there is no problem in the perfusion. Blood is going in its usual manner, but ventilation is not taking place. Gas exchange is not taking place. So we call it as a VQ mismatch is happening. VQ mismatch. So ventilation perfusion ratio, there is a mismatch here. So when there is a ventilation perfusion mismatch, then our body has a natural tendency that it will, because of that hypoxia situation here, so what will happen? They will vasoconstrict these blood vessels. So as a result, it will lead to hypoxemic vasoconstriction. So next, what will happen when there is VQ mismatch, when the gas exchange is not taking place, these blood vessels, they will be vasoconstricted. This is the normal thing, vasoconstricted. So there will be vasoconstriction here, and so most of the blood will then flow to the other normal alveoli. Okay, it will flow towards other normal alveoli. Because here it is obstructed, because the gas exchange is not taking place in this disease alveoli. So this is a normal reflex mechanism because of the shifting of the potassium channels. Okay, and what will happening here? This particular capillary will becoming vasoconstricted. So that is called hypoxemic vasoconstriction mechanism. So whenever there is VQ mismatch, there will be hypoxemic vasoconstriction of this particular capillary. So it is a natural way that most of the blood are being now diverted towards the healthy alveoli. If that is not done, what will happen? If there is no hypoxemic vasoconstriction, what will happen? Then there is no gas exchange taking place. So most of the carbon dioxide is going to the left ventricle. So there will be increased carbon dioxide in the level in the body, and there will be decreased oxygen level in the body. So to avoid that, our pulmonary system, they do the hypoxemic vasoconstriction. So this particular capillary is being constricted and blood is diverted towards the healthy alveoli. Now when this COPD is going on for a long time, what will happen when most of the alveoli are affected? Let's say here, so this is just the case of one alveolus. So suppose this is the, okay. So let's say most of the alveoli are affected here. Most of the alveoli are affected in a long run. Most of the alveoli means many pulmonary capillaries are now vasoconstricted. So when so many alveoli are affected, so there is equal number of so many pulmonary capillaries will be hypoxemic, go for hypoxemic vasoconstricted. Now these capillaries, where they are coming from? They are the branch of pulmonary artery. This pulmonary artery is coming from where? They are coming from the left ventricle. They are coming from the left ventricle. Now when there is multiple vasoconstriction, so obviously now this left ventricle has to pump the blood against such a resistance which is being developed in lungs. So you can see there are so many pulmonary capillaries which are branch of pulmonary artery. They are vasoconstricted, okay, because of the multiple alveoli are affected. So when there is a widespread pulmonary capillary constriction, so as a result pressure here, what is happening here? There is pulmonary hypertension. So blood has to go through a resistance, so which is creating a situation of pulmonary hypertension. So what happened here? Here there is pulmonary hypertension. Now the left ventricle will have to pump against a increased resistance that is developing in one of the lung. So left ventricle has to do lot of workload now. The workload in the left ventricle has increased. Before COPD, it is pumping, the whole thing is going normally. So left ventricle does not need to put any extra effort. But now there are so many obstruction here, it has to put extra effort. So sooner or later, this left ventricle will be now hypertrophied, because it is working against a increased workload. So this hypoxemic vasoconstriction will lead to pulmonary hypertension. It is leading to now left ventricular hypertrophy. So when this left ventricle is hypertrophy, now the heart is affected. Now listen here. The heart is the left ventricle, not the left ventricle. Let me correct, it's right ventricle. Okay, so pulmonary artery comes of the right ventricle. Okay, my mistake. Apologies for that. This is the right ventricle. So the right ventricle is pumping the blood against this resistance. So that's why the right ventricle will soon becomes hypertrophic, because it is doing an extra effort. So now you see this right ventricle has hypertrophied because of the lung. Right ventricle has got no mistake. It is not affected because of its own heart problem. It is being affected because of the pulmonary hypertension, or which is developed because of COPD here. So this condition of the heart that is affected because of the lung, we call it as a cor pulmonale. So ultimately there will be situation of cor pulmonale. So that is, you have to write in gas exchange. Okay. So in pathophysiology, you will write three things: airflow obstruction, then there is hyperinflation, and there is gas exchange. So in the gas exchange, you will write about VQ mismatch, hypoxemic vasoconstriction leading to pulmonary hypertension, right ventricular hypertrophy, and cor pulmonale. So that occurs, that is the pathophysiology of COPD. So that is for today's video. In the next part, we will discuss the clinical features and other treatment part. Thank you.